specifically here in the United States, I mean, we live in a first world industrialized country, but yet we have mortality rates that's 5 years worse than the rest of the world. Do you feel like a good reason for that is because of the quality of food that we have here?
The quality of food is a big part of it. We know that the reason that you develop inflammation in the gut is because of the quality of the food. So you highly processed food, rich in fructose, is all conduits to overwhelm the system in processing it. And once you get the system overwhelmed, what happens is inflammation. So that's in simplistic term. Think about the gut as a processing machine. You're loading it with a substrate that is very difficult to handle, and you're overloading it, so the machine heats up and becomes inflamed and eventually breaks down. So that essence, so the quality of food is an important part of the equation. Genetics is also a big part of it. We know that the disease have genetic background as well, but also sleep, physical activity, life stressors, other medications. So it's a very complex disease that I think it's a perfect storm rather than a smoking gun of an individual contributor.
Welcome to the #1 show and the source of truth for all things medtech. Here, we reveal the secrets and stories behind the investments, science, and commercialization of the medtech industry. Every week, we'll take you on a wild ride with the biggest names in the game, from entrepreneurs and investors who are shaking up the market to healthcare providers who are revolutionizing the way we think and practice medicine. So hold on tight and get ready for a journey like no other. This is the State of MedTech. Hey everybody, welcome back to the show. We have another exciting CME-based episode. This was a live episode that we did last week, and it's a really exciting one. This is the first one we did around endoscopy. So the world of bariatric and metabolic endoscopy has become very interesting, and I think more interesting is that as the technologies have evolved, we've found ways to use technology to not only predict illnesses and pathologies, but if you do this the right way, it can help prevent other things and, of course, more serious pathologies. So for this, I had the very esteemed Dr. Barham Abudayyeh join us. And let me tell you a little bit about Dr. Abudayyeh. And again, he prefers I call him Barham because we've become good friends. But he's the Assistant Medical Director of Business Development over at the Mayo Clinic. As the Assistant Medical Director for Business Development and Associate Research Chair of Innovation for the Department of Medicine at the Mayo Clinic, he leads the development and implementation of innovative solutions for complex human diseases. He has about 15 years of experience in advanced endoscopy, and he's a proven track record of delivering cutting-edge research and clinical outcomes in minimally invasive procedures and devices. So again, because of his role in innovation, he touches so many different products, different technologies. That's why I chose to have him on the show. He also holds a master's in public health from the Harvard T. Chan School of Public Health, where he developed his skills in health communication, quality improvement, and clinical research methodology and teaching. He's also the professor of medicine and the inventor of multiple medical devices and surgical endoscopic procedures. Again, the combination of him being on the innovation committee at the Mayo Clinic, inventing and developing medical devices, and his current professorship at the Mayo, all these things make him the perfect guest for this topic. His mission is to advance the science and practice of endoscopy and improve the outcomes and quality of life of patients with gastrointestinal and metabolic disorders through innovation and technology. So that's our episode with him. Be sure to click the show notes below. If you're a clinician, you get a free CME credit from this as part of our partnership with CMify. All you got to do is click the show notes below and write a few sentences of what you learned and what you will do with the information. And then I'll unlock an AMA PRA Category 1 CME credit. And finally, if you're a medtech company, you're interested in working with the State of MedTech to deliver high quality, engaging, entertaining, and educational content to a large clinical audience, hit us up. You can send me a message on LinkedIn or shoot us a message at hello@khateebandco.com. That's KHATEEB as in boy, ANDCO, or go to khateebandco.com. submit your information there. We can have a meeting, because again, probably the most important thing is that we look for industry partners to help develop and produce these great events. For this one, the State of MedTech bankrolled this one, but I'm hoping that we can find some great industry partners for 2024. And finally, if you're a software company and you're looking for a great MedTech audience, look no further. Look to become a sponsor of the show, as we are the number one show in the MedTech industry with a huge audience of MedTech professionals, investors, and physicians. Now, with that being said, let's get on to our episode with Dr. Barham Abudayyeh as we talk about advances in endoscopy. Enjoy. Hey, everybody. Welcome back. And thank you so much for joining us. So I'm joined by a good friend, Dr. Barham Abudayyeh, who is a professor of medicine over at the Mayo Clinic in Rochester, Minnesota, also an innovator. Now, we're going to talk about bariatric and metabolic diseases, specifically when it comes to treating them with endoscopy. It's an interesting area, and I talked to Dr. Abudayyeh, who insists from now on that I call him Barham. So I'm going to say that just so that the reps, they don't say, "Oh, you should have been more respectful by not calling him doctor." No, Barham asked me to do that. But Barham, why are we going to talk about this? We talked earlier about the importance of looking at a leading indicator when it comes to GI and metabolic disease. If you can kind of expand on that first before we kind of dive into the nuts and bolts of it.
Absolutely. Well, thank you, Omar, for this opportunity and to hosting me on this webcast. I'm pretty much convinced and convicted that the GI tract represents a novel and an important untapped therapeutic target for metabolic diseases. In an era where excess adiposity or obesity is reaching about 50 to 60% of the population, along goes with it metabolic diseases like type 2 diabetes, we really need to expand the therapeutic offering and have novel therapeutic targets that not only work on downstream effects of the disease, but try to modify and work on upstream therapeutic targets to reverse the clock, in essence, on metabolic diseases such as type 2 diabetes. I truly believe that the GI tract represents one of these novel targets, and we have data from bariatric surgery to support this notion. And now our task as interventionalists is to find the minimally invasive anatomy-preserving solution that targets the gut for metabolic benefit and to reverse the clock on diseases like type 2 diabetes.
Fantastic. Yeah, and I think, what I like about this, Barham, is that, so with that being said, I'll turn it over to you. Let's jump into your presentation. I'm very excited for it, and I know that the audience is as well.
Thank you, Omar. I will pull my presentation, and I'm hoping this will be more of a dialogue rather than just a presentation, so feel free to. Awesome. Before we start, it's always important to highlight why are we doing what we're doing? Why are we spending this time, energy, and money to develop solutions for unmet clinical need? And to clearly state the story, it's very important to highlight the magnitude of the problem. And we're going to focus here on type 2 diabetes as a use case. These are numbers from the CDC. 37 million Americans have type 2 diabetes. That's a lot of patients with the disease. But 96 million have prediabetes. That means they're on their way to develop type 2 diabetes. And the issue is 8 out of 10 do not know that they have the disease. That means we're dealing with the tip of iceberg when we're dealing with metabolic diseases, and the hallmark of which is type 2 diabetes. So there's significant clinical burden to the patient and the healthcare system when we're dealing with type 2 diabetes. When we look at the past 20 years or so, here in this graph, we represent Americans, adult Americans with diagnosis of type 2 diabetes who witnessed the introduction of multiple breakthroughs in the disease, multiple effective drugs, insulin, and other treatments for type 2 diabetes. But you could see, although we have made strides in improving outcomes of the disease, there's still significant unmet burden. And the unmet burden is, as we know, that if you get diabetics to be under optimal glycemic control, that means hemoglobin A1C less than 7, their macro and microvascular complications of the disease improve. But what this graph shows us that despite introductions of multiple effective drugs and insulin, over the past 20 years or so, about 50% of Americans do not reach optimal glycemic control. That means there's still significant unmet need in how we treat the disease of diabetes, and we need novel therapeutic targets that targets upstream, not just downstream signaling, but upstream signaling of the disease to modify it in order to improve this unmet need in that disease. So if we look at the fact sheet, how much this burden is costing our healthcare system, first of all, it's costing many, many lives. About 393,000 Americans died from type 2 diabetes in 2022. The annual cost of that disease is about $412 billion. Most of it are the direct costs of taking care of the disease, as shown in the slide. The costs have been increasing significantly. Compared to 10 years ago, we are spending $80 billion on that disease, again, despite introduction of many effective drugs and insulin. We should be spending less, but we're spending more on this disease, and the medical expenditures are increased by 2.5 or 2.6 folds compared to non-diabetic patients. If you hone down on one of these important statistics is the use of insulin, because we in medicine associate the use of insulin as patient is progressing down the disease path, that their pancreas beta cells stop working well, so now you need to supplement a non-functioning gland or a pancreas that's not producing enough insulin, and you're introducing insulin. Insulin is needed for patient care. It does improve outcomes in type 2 diabetes, but insulin causes weight gain, and it's a little bit of catch-22. That means you initiate insulin, patients gain weight, and it becomes more of a progressive disease that that you're fueling its progression with the weight gain that we see with insulin. And what we're spending on insulin alone is about $22 billion in 2022. So there's significant burden to the disease and still significant unmet clinical needs that we're dealing with. So the good story here is mortality from metabolic diseases such as type 2 diabetes has improved over time, but it's still double the mortality of patients without type 2 diabetes. So still dealing with significant morbidity and mortality burden of the disease. And when you look at why mortality has improved, and these are the bar graphs in blue, you could see most of the improvement are because we are better in managing vascular catastrophe. Somebody has heart attack, we know how to revascularize the heart. Somebody gets a stroke, we know how to improve the outcomes of the stroke. So most of the improvement in mortality are the results of improvement in managing vascular complication rather than modification of the disease itself. As you see from the green graphs and from the red, both cancer related to metabolic diseases is not improving, it's still the same percentage, and non-vascular issues also not improving. Therefore, I think we need this, treatment modalities that targets the inflammatory cascades that comes with metabolic diseases, such as type 2 diabetes, to improve the global mortality and morbidity burden. So the unmet need is the following. I love to use analogies. So think as metabolic dysfunction as a dysfunctioning orchestra. In the current treatment paradigm, we're targeting the flute player separately from the violinist, where we have to improve outcomes, target the orchestra conductor rather than the downstream effects of this malfunctioning orchestra. So in essence, we have a patient with type 2 diabetes. They develop insulin resistance. We give them a bunch of drugs that improve insulin resistance, and that's akin of targeting the flute player separately. Then they progress, they develop beta cell insufficiency, and now the violinist is not playing well, so we give them insulin to supplement that function, where there's an opportunity that in addition to targeting the violinist or the flute player is to reorganize or restructure the orchestra conductor in order to conduct a more efficient and better orchestra. And that's where the GI tract provide significant promise in treating upstream the disease in order to enhance the effects of novel pharmacotherapies for the treatment of type 2 diabetes. To illustrate that concept a little bit, there has been a very nice randomized trial published in our flagship journal in medicine, the New England Journal of Medicine, where they took patients with type 2 diabetes and they wanted to maximize their glycemic control. We wanted to improve this number. We wanted to get most patients to achieve a hemoglobin A1C less than 7. So they randomized them to get maximum dose of metformin, which is a common drug given for type 2 diabetes. And then they randomized them to either get an SGLT2 inhibitor, another modern drug that improved outcomes in diabetes, or a sulfonylurea, or one of the common and now kind of very popular drugs, the GLP-1 agonists. These are injectable drugs that are an analogs to gut hormones like GLP-1, or they gave them basal insulin. And then they followed them over time. What you could see is the top graph is the rate of patients per year that went out of control. That means that they surpassed the hemoglobin A1C of 7. And you could see, regardless of the randomized strategy, about a quarter of patients per year fell out of the range of optimal control. That means that they progressed to a hemoglobin A1C more than 7. When you look at the years from randomization up to 4 years, and you look at the cumulative incidence, you could see now that more than half, or the majority of the population, have progressed to achieve a hemoglobin A1C more than 7, indicating less than optimal control of type 2 diabetes. What that tells me is these drugs are important and they really improved outcomes in management of type 2 diabetes, but we're still dealing with a chronic progressive disease that could benefit from upstream treatments that could reverse the progression of the disease, not just treating the symptoms and that are progressive over time. Now, when we look at targets, why do we feel so passionate about the GI tract being these novel therapeutic target? Because we had data from bariatric surgery that's been there over many years to illustrate how important the GI tract is in type 2 diabetes management. This is a procedure called Roux-en-Y gastric bypass, where basically we're doing a few things, but the principle is we're creating a smaller stomach to cause restriction, and then we're bypassing the small intestines, the proximal small intestines, for a metabolic benefit. So to state it in simple terms, we're rearranging the GI tract for metabolic benefit. When you rearrange the GI tract, compared to what happens with medications alone, let's see what happens with bariatric surgery. This is also long-term randomized trial to see the outcomes of bariatric surgery on glycemic control, not only over 4 years, but over 10 years. And the graph the graph in blue and the graph in green represent bariatric surgery, versus the graph in red represent medical therapy for the disease. So unlike just treating with medication, where patients got out of control at the 10-year follow-up and their hemoglobin A1C on average was about 8, both arms that rearranged the GI tract, whether Roux-en-Y gastric bypass or a procedure called pancreatic biliary diversion, they maintained optimal glycemic control with a hemoglobin A1C less than 7 throughout the 10-year duration of the study. Now, with this regeneration or reversal of this metabolic disease, you look like the medical arm, those were treated with medication alone, 50% of them at follow-up required insulin initiation, versus those in the bariatric surgical arm, only 5% in the gastric bypass and 0% in the pancreatic biliary diversion required initiation of insulin. So what that tells you, Omar, is if you target the GI tract, you will have substantial metabolic benefit that not only treat the disease, but could reverse the clock on the metabolic burden of the disease, so you're not progressing as we would see with medical management alone. And that's why we got excited to leverage the GI tract in an anatomy-preserving fashion for the treatment of type 2 diabetes to augment what you would see with medications alone, because we feel it's a novel therapeutic target that meets significant burden of of disease with significant unmet needs. And the GI tract is quite complex. So here we're going to indulge a little bit in physiology and pathophysiology just to illustrate how we could target this orchestra conductor to better manage the disease. So here I'm showing a picture of the GI tract just to orient our viewers. Focus on the stomach, which is the reservoir of food, and the first part of the intestines, which is this portion right here called the duodenum, where it's now tasked to organize the response of the body to that food. So that means you eat a meal, the duodenum now has to orchestrate a metabolic response in order to handle that meal, or we're going to have problems with hyperglycemia if the duodenum is not doing that. So then if you blow out that duodenum, or first part of the small intestines, you could see that it's a very complex structure that includes multiple projection mucosal cells that communicate with nerves in the duodenum, and through this interaction between these mucosal cells and these nerves, the duodenum is organizing a significant response to the metabolic burden in order to manage it. In states of type 2 diabetes, we know that this structure becomes inertic. It does not work as well because it gets inflamed, and we currently do not have any treatment to reverse this inertia or inflammation that we see in the structure to target it for a treatment paradigm for type 2 diabetes. So this simplifies it a little bit more. You could see we eat our food. Our food interact with multiple bacteria in the gut called the microbiome. And these metabolites of the microbiome with the food interaction with multiple cells in the lining of the duodenum convey these signals to the nerves in order to target the metabolic effect of how to digest and how to process the glycemic load. In states of type 2 diabetes, things get inflamed in the structure, so the signaling between these cells and the gut nervous system becomes altered, and the body or the duodenum becomes inefficient in managing the glycemic load, and it is a therapeutic target for both the inflammation that comes with the metabolic disease, but also for glycemic benefit if we could get the structure to work better. So that has been endoscopy provide tools to easily access the structure. So this is a small camera that through your mouth, we could make it to the duodenum, and now we could develop or deliver therapies to the duodenum for treatment of type 2 disease. If you could see here, I'm using this magnification on that lens, and I'm using a technology called narrowband imaging to highlight the rich ecosystem within that duodenum. These are the mucosal cells that I showed you earlier that could get damaged and stop interacting with the gut nervous system in order to handle the meals. It looks like a healthy coral reef when you look at it like this. What we've seen in states of type 2 diabetes is a slightly different picture. You could see there's erythema, there's increased vasculature within that structure, and there's these deposits that look like fat and chyle. So you could see how this structure becomes inflamed and stopped working well in states of type 2 diabetes. And our goal is to deliver therapy in order to regenerate the structure in order to function better in responding to the metabolic load.
Barham, I have a quick question for you.
Yes.
So something I was gonna say is that when it comes to like the gut microbiome, in the last I think 5 years, a lot of investment has gone into that area. There's different companies that are focused on the gut microbiome. From your standpoint, when you try and regenerate and rejuvenate these structures, it's kind of a chicken and egg thing. Is it that you're focused on regenerating the microbiome itself or the underlying structures of the gut? Or do we not know which one's which?
This is a key question, Omar, and that's one of a very intense area of research. And you alluded to it. Is it the chicken from the egg or the egg from the chicken? I mean, I told you with states of metabolic disease, the duodenum or the gut becomes inflamed and communicates this inflammation elsewhere. So the gut immunity is revved up. And when you get the gut immunity revved up, you could cause dysbiosis or alteration of the microbiome from that structure. So that means that you're probably targeting both. With rejuvenating or regenerating the structure, you're resetting the gut immunity in that structure. You're resetting the gut enteric nervous system signaling, but also you're allowing the gut to regenerate with a healthier microbiome as long as the patient introduce healthy food choices, because it's a fine balance between what you eat, the gut immunity, and the metabolic inflammation or the inflammation that is occurring in that structure at that point of time.
Got it. That makes sense.
So the idea here is we want to replicate the benefit of bariatric surgery, but without with preserving the organ and allowing scalability. That means developing endoscopic intervention that scales the benefit of bariatric surgery without losing the organs or rearranging the GI tract. And that is the concept of using the gut in an organ-sparing, safe, and effective fashion that has very little long-term consequences to health and minimally disruptive to the patient's lifestyle, in order to leverage the gut as a therapeutic target and scale its use for treatment of diseases like obesity and type 2 diabetes. So now we're going to focus on this technology developed by a company that I'm one of the inventor on it, called Indogenics. The company is based in Minneapolis, and it's developing the first non-thermal regenerative energy to allow us to regenerate a sensitive structure like the duodenum. And that energy is based on the concept of electroporation, which we're going to describe a bit later. But this company is laser focused on developing novel therapeutic targets for treatment of type 2 diabetes, with the focus on using this electroporation to regenerate the duodenum and achieving metabolic benefit as an added treatment or management paradigm for type 2 diabetes. So what is electroporation? Electroporation basically is we're introducing a high voltage electrical field, but for ultra short bursts. So what happens to any cells that has a covering, or what we call phosphobilipid membrane, it will have multiple pores in it, and the cell will regenerate without affecting what's surrounding the cells, or the extracellular matrix, or the blood vessels that surround this area. So any biological cell with this phosphobilipid membrane, as shown here, while you introduce this electrical field, is going to have these micro holes in it, and these micro holes is going to be enough to have the cell goes into programmed cell death and regeneration without affecting the extracellular matrix and without damaging surrounding organs in the process. So that what defines electroporation versus heat-based modality that provide indiscriminate damage to both the cells and the extracellular matrix and the lymphatics and the blood vessels in that structure. So how is this administered? It's administered through this catheter. The patient is asleep in an outpatient endoscopy unit, and you're introducing this flexible circuit under endoscopic guidance without altering the anatomy. And as you could see, when this flex circuit opens up, you're introducing these bursts of electricity that, without heat, regenerate any living cells in the structure while maintaining the extracellular matrix and the vasculatures and the lymphatics. And now the hope is you have regenerate or reverse the clock on the metabolic disease for the metabolic benefit that comes with that. And as you could see from this animation, we do it at a segment of about 12 centimeters or so in the duodenum. And again, it's an outpatient procedure. The patient recovers in the endoscopy unit and then gets to go home in the same day after this procedure without altering the anatomy. So it's truly a regenerative paradigm or regenerative medicine paradigm for the treatment of type 2 diabetes. So the idea here is, if we look at on the x-axis invasiveness of intervention and on the y-axis the efficacy and durability, now we're having lifestyle interventions that are the cornerstone of any management strategy, but we have multiple effective medications that manages type 2 diabetes. We also have bariatric surgery that I showed shows significant benefit to patients with type 2 diabetes. But the idea now is having a regenerative medicine paradigm that decrease the need for insulin, work with the modern medications like the GLP-1 agonist in order to reverse the clock, not just delay things from progressing, in order to replicate the benefits of bariatric surgery, but with preserving the anatomy and in a scalable fashion that could apply to a wider segment of the population with the disease.
And
So
Barham, real quick, if you can go
yes,
back to that, I was going to ask a couple questions. One is like one of your main thing you had mentioned about preserving the anatomy. So traditional bariatric surgery, it obviously doesn't. The important part about preserving the anatomy is essentially the extent of the microbiome and the underlying anatomy, correct? Because once you remove it, right, you're functioning with with less of the anatomy, right, which is not necessarily good. What I wanted to ask you is that for reset, which by the way I like the acronym and abbreviation for it. What's your patient selection look like for that compared to like your usual treatment for GERD?
yeah, absolutely. So right now, Omar, it's in investigational trials only. So we initiated FDA trials, and there is about experience from about 100 patients in 3 countries: Australia, Netherlands, and the US on FDA trials. We're embarking on a pivotal trial soon, but currently the patient criteria is patients who are not reaching optimal glycemic control on multiple oral or injectable agents. That means they're embarking on insulin, but they have not initiated insulin yet. So the idea is to take these patients that are medically managed for type 2 diabetes by not reaching optimal control and try to reverse the clock so they do not progress to requiring insulin for the treatment of their disease. In Amsterdam, Professor Bergman did a kind of an interesting study where his goal was not only to prevent the progression to insulin, but to withdraw insulin on patients. So he took patients with diabetes on insulin. These patients are on basal insulin mostly, and his paradigm was to use the reset technology or to do the reset procedure and add a GLP-1 agonist in order to withdraw insulin while maintaining optimal glycemic control. He did this study. It's a proof of concept study, and now they presented it in a couple of our international meetings. And in about 85% of patients, they were able to remove insulin while achieving better glycemic control in these patients, which was very interesting finding. And of course, we need to still confirm it in more randomized trial, but at least within the confound of this prospective clinical trial, they showed significant benefit of the combination of the reset procedure with the GLP-1 agonist drugs like liraglutide or semaglutide.
Got it. And I was going to say, just for the audience who's not completely familiar with it, I know that there's a lot of discussion about GLP-1. First, can you make sure to explain what that is? There's something I wanted to share, which will be interesting. But yeah, can you explain what GLP-1 is, because it's been in the news quite a lot lately?
Absolutely. So GLP-1 is a gut hormone. So it's a peptide that is released from the gut in order to enhance the metabolic response when we eat a meal. For example, you eat your lunch, and now the stomach mixes this food. The food is going to make it to the small intestines. The food interacting with the lining of the small intestines release a hormone called GLP-1, and there's others that they collectively are referred to as gut hormones. And these hormone has metabolic function and metabolic end results to help you digest and metabolize the meal that you just ingested. Now, as I showed you in one of these graphs, most of the function of these gut hormones are at the level of the gut itself. That means covering interact with the food and the microbiome. It releases these gut hormones. These gut hormones activate receptors on the nerves within the wall of the small intestines, and these gut nerves then activate end metabolic organs like the liver, pancreas, or central nervous system to orchestrate the metabolic response. With the GLP-1 drugs, we chemically modified these peptides to have them now linger longer in the bloodstream in order to enhance their metabolic benefits. So these gut hormones now, instead of being broken down quickly in the gut stream, they could last in the gut. They could last in the bloodstream for longer, like a week at a time. And these gut hormones have significant metabolic benefit. They work on the central nervous system to decrease appetite, so patients eat less. They work on the GI tract to delay by the rate by which the stomach empties, so patients feel full for longer. And they also work on the pancreas in order to enhance its function in producing insulin and on insulin resistance. So they really have multiple end targets. But the idea is they originate from the GI tract and have significant metabolic targets that help managing type 2 diabetes. So you could see a scenario where you're not only giving the substrate with these gut hormones, but regenerating the receptors in the gut through a technology like Reset in order to combine the benefit of both intervention and to prevent the progression of diseases like type 2 diabetes and reverse the time clock on these disorders.
Got it. And so the idea is essentially using a combination of an intervention like Reset and then GLP-1 in tandem with it. And, the reason why I bring up GLP-1 is that, it's had such a large impact on patient populations that even there's a recent publication or coverage on Stryker, because the idea is that with GLP-1, the concern was that Stryker was going to see a reduction in its market cap because of people losing weight. But in fact, GLP-1s have such a big impact. Stryker's general manager believes that it's actually going to create an uptick in more people receiving procedures like total knees, et cetera, because now those patients who are obese did not qualify for those procedures, but now that they do. And so, one of the issues we see often is the issue with gastroparesis with insulin. I'm wondering, between GLP-1 and Reset, what does that look like? Is there a similar impact on gastroparesis? And
so that is a very important question, because there's no perfect intervention for either obesity or metabolic diseases. Everything is risks and benefit, including the GLP-1 agonist. So the GLP-1 agonists, though effective, they have issues of costs. They have issues of compliance. And as you rev up the system, once you stop taking these agents, their weight and their metabolic benefit are reversed very quickly if you stop them for a short period of time. There's issues that the body gets used to any intervention in this space, and you might delay progression, but ultimately, if you don't modify the disease, you need to continue to escalate therapy and get to insulin. And there's some GI adverse events to these drugs, including delay in gastric emptying itself or because of the GLP-1 agonist. And there's some other issues with pancreatitis, what have you. Now, they're definitely a welcome addition. They're going to help us manage patients with type 2 diabetes, and they're going to be an important cornerstone in the management. But they have some issues related to the areas that I highlighted, and therefore combining them with a GI focused or an intervention that targets the gut in order to kind of not only treat the downstream effects of insulin resistance and beta cell insufficiency, but try to modify the inflammatory signals that originate in the drug in order to improve the outcomes globally on type 2 diabetes. And it's what we call the cardiometabolic burden of it, because glycemic control is good, losing weight is good, but unless you improve the global inflammatory picture that is associated with cancer, with macro and microvascular complication, you're still dealing with a significant burden of the disease. So the hope here is combination, disease modification, and introducing novel therapeutic targets that in combination will allow us to spare patients from progressing to insulin and reverse the course on type 2 diabetes. None of these interventions are going to work in silo, and not all patients will respond in the same fashion to these interventions. Therefore, I think we're going to be embarked on an era where we're going to personalize the choice of the intervention to the patient pathophysiology, and we're going to start mixing and matching in order to better impact the disease, Omar.
Got it. Fantastic. Thanks for expanding that. I'll let you keep going.
Actually, that's a really good segue, because I have a patient in one of our studies that demonstrate how these things could work, or how this intervention could work. Again, I would emphasize that this is still in clinical trials, but we had a patient, 68-year-old male, body mass index of 34. So the patient had obesity. They had type 2 diabetes for 5 years, and you could see that they've been managed with modern medications. These are the DTP4 inhibitors and the SGL2, but despite being on 2 drugs, the hemoglobin A1C was at 8.4. So they're not achieving optimal glycemic control, and that has a consequence. So the patient qualified to participate in this trial and did undergo the reset procedure as part of this trial. Let's see here. So they got the treatment. I'm not sure that video is playing, but they got about 6 treatments with the treatment modality. And this is what happened, Omar. This is at baseline. You're seeing the time and range using continuous glucose monitoring and the hemoglobin A1C. At baseline, the patient hemoglobin A1C was 8.4, indicating suboptimal control on medical treatment alone. The time and range of their glycemia, as shown in the first graph in the number, was 51%. That means in the yellow on the first graph in the series, that the patient had multiple episodes where they're not achieving optimal control or optimal glycemic control in the 24 hours period. So now they got the reset procedure, and what you could see that at 4 weeks they had significant improvement. At 24 weeks they achieved a optimal glycemic control with a hemoglobin A1C of 6.8, and along goes with time and range. So as you could see now, you see less yellow in these graphs, and you see lots of gray. That means you're within the bounds of optimal control, whether when you're sleeping or during the daytime, indicating that modifying the gut has helped the medication get this patient under optimal glycemic control with the benefit that comes with that. And that's why we're very excited. You could see how this could become a really good synergy between modern drugs and disease-modifying interventions that work on the gut in order to reverse the signaling that currently is not being targeted by drug therapies alone to impact that disease. And maybe, Omar, I think that's the end of the official slides, but I will stop sharing, and maybe we'll have a discussion about any questions that you might have.
Yeah, absolutely. So, like, I think the one of a couple of themes I took away here, which is like, in the past, we had very aggressive treatments, whether it's like complete removal of certain parts of the anatomy, as we see in bariatric surgeries, or a lot of drug interventions, right? And so the shotgun approach at the time was the best thing, because before that there was really nothing, right? But now, as we're kind of becoming more predictive and precise with medicine, we're starting to understand the importance of essentially maintaining the underlying anatomy, right? And so the first thing I want to kind of talk about, or I want to go back to, is that on the reset therapy, the idea is that the past was ablation, which was, again, more of a shotgun approach. This, I think, pulse electrified therapy, correct? It provides a little bit more of a precise approach and maybe not as aggressive. Is that correct?
That's correct. So it's pulse electrical field, and what it does is it's because its athermal nature allows you simplicity of delivery. That means you need more operators to be able to do the intervention. So the fact that you do not need to do a complex procedure, you just put a catheter and let the generator with its computer algorithm deliver the therapy without thermal damage is an important concept, because now you could open your users to many gastroenterologists, hepatologists, and surgeons who could do endoscopy. So that's one of the principles, is the ease of use of the technology. The second principle, which is equally important, is it's athermal, so it's regenerative in nature without causing collateral damage. So it could reverse the changes that are associated with type 2 diabetes in the duodenum, for example, without causing collateral damage. That means the treatment becomes repeatable. So let's give a scenario that somebody has type 2 diabetes. They are on multiple drugs, including a GLP-1 agonist. And as shown from the data I presented, that at 4 years, they stop responding to these agents, and now they're getting under suboptimal glycemic control, and they're looking at the macro and microvascular complications that comes with the disease. So at year 5, instead of initiating insulin, you could offer the patient the reset procedure. Now you put them under control for the next 2 years. But then you could repeat the procedure which is outpatient, anatomy preserving, and athermal every 2 years to maintain the disease modification and maintain the response to the medication without progressing to insulin. And that becomes the interesting part of a very selective and safe approach to leverage the gut as a treatment modality for type 2 diabetes.
Got it. That makes sense. So if you can kind of scope out, like, let's say, 5, 10, 15 years from now, what would be the best case scenario for a patient in this situation? Like, because again, the whole purpose of these new innovations and these new approaches is to do it earlier and obviously in a less aggressive format. So if you can give me like a patient persona type, age and everything, what would that look like? And then what would be essentially I guess the old way, that we're trying to move away from is that you get a patient who's in their 40s, 50s, and 60s, and they've gotten to a point where their gut microbiome is completely obliterated. They've been scorched earth, as they say, with drugs and everything. And so there's not so much you can do. So now you have to start taking away some of that underlying anatomy and having more of these aggressive approaches. So if we reverse the clock back and we have these patients earlier, what does that patient persona look like? What's their age and everything? And what's the treatment approach and the prognosis that you take now?
Yeah. So to talk about the future, I think we're going to start dealing with a couple of new concepts and paradigms. The first concept is personalized medicine and precision medicine. That means we're going to have to better understand what's driving the metabolic disease in a particular patient and start the initial treatment targeting the biggest bang for the buck is to target that physiology. So what we're going to see is leveraging artificial intelligence, generative AI. We're going to start using clinical parameters and using maybe biopsy of the small intestines and using a biochemical profiles of hormones in the blood or substrate in the blood to predict what's driving the disease in a particular patient and starting the treatment to target what's driving the disease. So that's the first principle. The second principle is going to be disease modification. And what do I mean by that? There's a lot of cool data that's evolving that's showing that inflammation in the gut and an entity where the gut microbiome is altered called dysbiosis is associated with increased incidence of inflammation in the heart, increased incidence of inflammation in the brain, such as Parkinson's disease or Alzheimer's. That to me is fascinating. That means the inflammation that originates in the gut is communicated with organs, and chronic degenerative diseases like Parkinson, Alzheimer's are associated with the inflammation that starts in the gut. But currently, we have no treatment to reverse the inflammation that starts in the gut and correct this dysbiosis. So bariatric surgery does that by rearranging the GI tract. So we know bariatric surgery fixes the dysbiosis and improves the chronic inflammation. So the hope, and we still need to prove that, the hope is that reset will reverse the inflammation in the GI tract, or at least in the duodenum, fixes the dysbiosis, alter this interaction with key end organs in order to treat these chronic degenerative diseases. And the idea here is not just to achieve glycemic control. The idea is hard endpoints. Could we decrease incidence of cardiovascular events, whether congestive heart failures, arrhythmias, myocardial infarction? Could we improve outcomes in neurodegenerative diseases associated with excess adiposity and inflammation? Could we improve the outcomes of cancer? There's data to show that the gut microbiome and the inflammation in the gut is associated with immune therapy response to cancers such as melanoma or what have you. So the idea is, could we modify the disease at its origin? And in my opinion, and again, this is biased opinion being a gastroenterologist, at the origin in the GI tract in order to treat multiple diseases with excess adiposity and chronic inflammation as their common denominator. So paradigm one is precision medicine and personalized medicine. Paradigm two is leveraging the gut as a treatment target to reverse the inflammation and the dysbiosis in the microbiome that comes with metabolic diseases and chronic degenerative diseases, We know that bariatric surgery does that, and bariatric surgery is going nowhere. I think there's going to continue to be a segment of the population where they have severe form of the disease that will always benefit from bariatric surgery. But now, could we increase access to the benefit of bariatric surgery by using these endoscopic procedures to now have more segments of the population qualifies for these interventions and decrease the barrier in adoption to treat more patients?
That makes sense. I have a follow-up for you, but I want to double check because I know I mean, being a professor at Mayo, your schedule's packed. Are you okay on your time right now?
I'm okay on my time. I think for 10 more minutes would be just fine.
Perfect. Yeah. So I think what's interesting is that I think it's a very exciting time to be in medicine, right? And I think the reason why is that in the past, as physicians, you had to wait for the end stage when something really goes wrong for a patient to come see you. I'd say in the last 5 years, and we can thank some big catalysts. Joe Rogan is kind of one of them, but more so like Andrew Huberman, Peter Attia, who are bringing the forefront of science and biohacking into the forefront. The gut microbiome is one of them, right? I think it's very interesting. There's that old saying is like, just go with your gut, and now we know that that's true. Mm-hmm. And what I'm wondering is, the consumer population is becoming more interested in health. And I think like in an industrialized country, once you've achieved everything, the end state is, sort of chasing mortality, right? Do you see in the future a possibility where the average consumer, right? Like I'll use myself as an example. So in my case, having Middle Eastern background, there's my family history runs rampant with like diabetes and heart disease, right? Do you see it in the future where the average consumer could come extremely early just because of a familial and history of these issues to get checked via endoscopy to see how is their gut microbiome? Like I'm healthy right now, but do you see in the future that consumers will say, I want to go ahead and pay cash and get my gut microbiome checked? And it's like, oh, you know what? Your gut microbiome, it's good, but it could be better if you had these few little interventions done from now. Do you feel like that's a possibility?
Yeah, definitely it's a possibility. And more than focusing on just the gut microbiome in isolation, we need to focus on on biomarkers of inflammation that originate in the GI tract. So it's probably going to be a possibility where you're going to get maybe a biopsy from your small intestines. You're going to profile these biopsies, understand your microbiome and your gut immunity and the inflammatory burden, and that is going to be a surrogate to problems down the line in the process. So I could see that happening, and I think we have really early data to indicate that that's going to be a possibility. But also it's important to highlight, and maybe that would be a good conclusion remark, that despite significant strides in medicine, we still in the US live 5 years less than other nations that are developed, though we spend a lot on healthcare. So I think part of that, there's multiple reasons for that, but part of that is we need to do better in managing chronic diseases. And we need to kind of go to root cause pathophysiology that modify the disease. So we're going to be in an era where we need to be in disease modification rather than just in disease treatment, which is very important distinction. Disease treatment indicates that you're just delaying progression. Disease modification indicates that you're reversing course on the disease. And that's why regenerative medicine is exciting. And now, unlike any time in history, we have the tools to really introduce regenerative medicine as a treatment paradigm for chronic diseases in order to modify their outcomes. And that's going to be an important principle as we move forward, is not only predicting your risk, but doing something about it by modifying the signals in order to reverse course.
That makes a lot of sense. I think this is a key thing here that you mentioned, which is, aside from assessing a risk profile, but instead of having the aggressive approach of like surgery, you have earlier interventions, right? To treat them, to sort of treat like localized sources before it gets worse. And then you have to have much more aggressive approaches. And with those aggressive approaches, you have a multitude of side effects that you end up managing as a result of it. I think that I don't know if it's very difficult to run a study like this, but I think a lot of the chronic diseases we see, heart disease, Parkinson's, these things, I think a lot of, if you do a root cause analysis, go back to things such as the gut and the microbiome from there. And I think the other aspect of it is that the knowledge that we're developing around inflammatory markers and inflammation. I mean, high cholesterol is a great example. High cholesterol is actually not the problem. The problem is that if you have inflammation with high cholesterol, that's when you end up throwing a clot and you can die, right? Mm-hmm. And I think it's the same thing with nutrition. One last thing I was going to mention before we let you go is, you mentioned about like sort of root causes, right? And specifically here in the United States, I mean, we live in a first world industrialized country, but yet we have mortality rates that's 5 years worse than the rest of the world. Do you feel like a good reason for that is because of the quality of food that we have here?
The quality of food is a big part of it. We know that the reason that you develop inflammation in the gut is because of the quality of the food. So you highly processed food, rich in fructose, is all conduits to overwhelm the system in processing it. And once you get the system overwhelmed, what happens is inflammation. So that's in simplistic term. Think about the gut as a processing machine. You're loading it with a substrate that is very difficult to handle, and you're overloading it, so the machine heats up and becomes inflamed and eventually breaks down. So that essence, so the quality of food is an important part of the equation. Genetics is also a big part of it. We know that the disease have genetic background as well, but also sleep, physical activity, life stressors, other medications. So it's a very complex disease that I think it's a perfect storm rather than a smoking gun of an individual contributor.
Got it. That makes a lot of sense. And as we wrap up, just for a lot of the consumers who listen to the show, I do have to ask, because I'll be my audience will say, why didn't you ask them that? As somebody who's an expert in GI, what do you like to eat in the morning? Or are you like most physicians where you just do intermittent fasting all the time because it's convenient?
No, I used to do intermittent fasting, but I realized again, as with anything, you want to work with physiology, and the more you restrict yourself, it's going to be harder to follow that program. So what happens is a period of rebound. You could do intermittent fasting for a couple of weeks. Life gets to you, you get stressed out, then you go and overcompensate, and the benefit of intermittent fasting is lost because you developed an unrealistic program. So what I like to do is developing a realistic program. So I do high protein, low carbohydrate diet that is based on healthy choices that include a lot of protein, some carbohydrate, but mostly unprocessed carbohydrates like whole grains and what have you. And what I do is I try to make sure I'm drinking a protein shake that has these macronutrients in it in the morning, so I know exactly what I'm getting, and one for lunch. And I save my dinner to a nice, healthy dinner with my family if I can. So that's the idea. Is you need to develop a program that's conducive to healthy living, not dieting. We could follow healthy living. Dieting is a cycle that we live in continuously. We cannot maintain, and it's the basis for this yo-yo diet.
I completely
You lose weight, you gain it back. So to me, the idea of a mindset of a healthy living, we know what we need to do. We develop an individualized programs to include what we can do in our daily routines. So I could follow physical activity, I could follow a healthy diet. And then if you have a diet high in protein, high in fibers, your gut inflammation is going to decrease and your microbiome is going to improve. And that's all it takes is healthy living.
I completely agree. And a great way to wrap up. Barham, thanks so much for coming on the show. I want to have you back on because there's a consumer side to like the healthiness of your gut and everything that we're definitely have to talk about. If you're a clinician watching this, don't forget you can get a free AMA PRA Category 1 CME credit. Thanks to our partners at CMFI. Just click the banner below or look at the link in the show notes. Go to that and be sure to write down what did you learn and what will you do with the information. It takes a few seconds. You get a free continuing education credit. So I'm your host, Omar Khateeb. This is another episode of the State of MedTech, and we will see you all next time.
Thank you for enjoying another epic episode of the State of MedTech. If you're feeling inspired and love this episode, do us a favor, hit that subscribe button and turn notifications on so you never miss an episode. And be sure to give us 5 stars and write a short review because that helps more people discover this amazing community of ours. If you're a company who has a executive that you'd like to be on the show, or perhaps you want to sponsor one of the episodes, shoot us an email at hello@khateebandco.com. Take care, and we'll see you next time.